All right, so now we're going to be talking about disorders of the aorta. So some fun facts about the aorta. It's the largest artery. It's about 2 centimeters in diameter, and it's about a foot long. The aorta is also broken into 4 different sections. So there's the ascending, the aortic arch, the descending thoracic, and then the abdominal aorta. So there's different areas when we talk about the aorta. All right, so the most common vascular problems of the aorta are aneurysms, aortoiliac occlusive disease, which is, we went over in the PAD PowerPoint slides, and then aortic dissection. So these PowerPoints will talk about aortic aneurysms and aortic dissection. So an aneurysm is a permanent outpouching or dilation of a vessel wall. The aorta is the most common artery for aneurysms, but it can occur in other arteries. Abdominal aneurysms occur more commonly than the other 3 areas of the aorta. Generally, we see abdominal aortic aneurysms primarily. And basically, this results in a weakening of the arterial wall. So aneurysms occur in men more often than women. The older we get, the more at risk we are. And atherosclerosis is a very common cause for aneurysms, seeing that a lot. And most occur below the renal arteries, which is a good thing because if aneurysms happen below the renal arteries, we can preserve kidney function if something were to happen or if they were to have some sort of repair for that aneurysm. So people can have aneurysms in more than one spot, especially because of atherosclerosis, if that's one of the common causes of aortic aneurysms. Usually we know that those atherosclerotic lesions can happen in more areas than one, which can result in more aneurysms than just one. So we define an aneurysm when the aorta is larger than 3 centimeters in diameter, because we just learned a fun fact that it's usually about 2 centimeters in diameter. Unfortunately, the growth rate is very unpredictable. So we don't know how fast, when an aneurysm is detected, we don't know how fast that's going to grow. So that kind of stinks. Obviously, the larger the aneurysm is, the greater the risk of rupture, and that's our #1 complication. And as our aorta becomes dilated, that wall can be lined with little pieces of thrombi in the same sense that unstable plaque happens in coronary artery disease. This unstable plaque in the aneurysm can break off and form little emboli. So some of the common causes are degeneration, which commonly atherosclerosis. There's some congenital abnormalities, which means that you were born with it, trauma, inflammatory disease, advanced age, tobacco use, infectious agents, and there is quite a large genetic factor as well. So these are some of the other risk factors, especially coronary artery disease and high blood pressure, high cholesterol. All of these things kind of play a role with each other. And let's not forget smoking. Smoking carries a risk factor for lots of different things. And as I said before, there's a fairly large genetic link, especially connective tissue disorders, such as Marfan syndrome, because it affects the connective tissue that's needed for strength and flexibility. So there's 2 classifications of aortic aneurysms. There's true aneurysms, which are actually aneurysms, and then there's pseudoaneurysms or false aneurysms that we'll talk about in just a minute. So this is a picture. So picture A and B are both aneurysms. There's 2 different types of aneurysms. You won't be tested on them, but just so you know, some of them can kind of look like a pouch, and other ones are just more rounded, as you can see in pictures A and B. C is a pseudoaneurysm, and then D is a dissection. So the wall of our arteries have 3 layers. So with a true aneurysm, there is the wall of an artery forms an aneurysm, so it's this outpouching, and at least one vessel layer is still intact. So there's no, that blood is still within the aneurysm, right? I mean, it's still within the artery. A false aneurysm is a disruption of all the layers of an arterial wall. So there is bleeding into the tissue, into underneath the tissue. Pseudoaneurysms can happen from trauma, infection, or leakage after a arterial puncture, such as when somebody goes into the cath lab and they have a femoral puncture because they're in the cath lab and that's the access site they're using, and they close it up, and then that clot winds up breaking off that is formed over the arterial wall and winds up leaking beyond that. So that's a pseudoaneurysm, which isn't really an aneurysm at all. So thoracic aortic aneurysms, typically referred to as TAA, many times patients are actually asymptomatic and they're caught by accident, meaning that they have a CT scan and it shows it, but it was unrelated to symptoms of an aneurysm. If patients are symptomatic, it's deep diffuse chest pain, which can be very similar to anginal pain. So clearly we would get an EKG, rule out whether anything is happening with the myocardium, and then get a CT scan to help rule out or rule in an aneurysm if patients do have chest pain. An aneurysm within the ascending aorta or aortic arch are more likely to have symptoms because there's not a lot of room for things to grow and they not be pressing on something or causing some sort of symptoms. So patients can have angina, secondary to decreased coronary blood flow, hoarseness, and even dysphagia. And again, that is from pressing on either the laryngeal nerve, pressure on the esophagus, depending on how big this aneurysm is. If the aneurysm winds up pressing on the superior vena cava, we can get edema in face, arms, and even some JVD just because they don't have the venous return. We have a little bit more room in our abdomen, so oftentimes patients are asymptomatic and aneurysms aren't detected unless there's a physical exam, which we might be able to visualize a pulsatile mass or feel a pulsatile mass in the abdomen that would be indicative of an aneurysm. Or it's found on some sort of diagnostic test, like a CT scan or an abdominal x-ray. Some of the other symptoms, if people do have symptoms, usually it's from compression on other body structures by that aneurysm if it grows. Other times patients can have constipation or bloating. And then there's this thing called blue toad syndrome, where little pieces of plaque break off and those little pieces of emboli wind up lodging in our smaller vessels, causing this blue toe syndrome. So the most serious complication is obviously rupture, either rupture into the retroperitoneal space or rupture into the thoracic area. So patients could have severe back pain. They might have Turner sign, which is back or flank ecchymosis or bruising. Unfortunately, most patients don't make it to the hospital and survive. So there are several different diagnostic studies that we do to either look for aortic aneurysms or to help rule out some of the symptoms we have, specifically chest pain. So a chest x-ray can actually detect a aneurysm if there is one. And then we have an ECG, and that's to rule out any other symptoms or any other reasons for angina that is common with our ascending aortic aneurysms and on the aortic arch. Ultrasounds can be a very useful, inexpensive, and fairly quick to monitor the aneurysm size. It's most useful in screening for aneurysms for those individuals who are at high risk. But our CT scan is kind of the gold standard. CT scan gives us the most information, and it's the most accurate. So it can give us the length, the cross-sectional diameter, if there's any thrombi because of that disruption of plaque. And it can help determine if surgical treatment is needed, the best type, because we're able to see other areas around that, the aorta, or specifically depending on where that is. MRI can obviously assess all of those that the CT scan can, but MRIs are lengthy and CT scans give us just as much information, so it's usually not necessary. And the last one here is angiography for diagnostics. This is mostly done in those aneurysms that are in the thoracic region or those aortic aneurysms above the renal arteries, because they can kind of determine the extent and map out the entire aortic system and figure out the extent that other systems are involved. So our goal is obviously to prevent aneurysm rupture, since it is an extremely high death rate if those aneurysms do rupture. Early detection and treatment is imperative. So for small aneurysms, we want to prevent, growth and help with risk factor modification. We can't reverse aneurysms once they've already started. So there's just medications to help prevent it from rupturing and hopefully growing fast. Like beta blockers, and actually there's some antibiotics as well, like doxycycline, that can help with slowing the growth of the aneurysm. If patients require surgery, or it's expected that patients will need to undergo surgery because of the extent of an aneurysm repair, they might need to do other surgical interventions, especially carotid and coronary artery disease correction prior to going in for an aneurysm repair. So for the most part, conservative therapy consists of our risk factor modification, smoking cessation, decreasing blood pressure, controlling our lipids, and then monitoring the growth size of that aneurysm, the size of that aneurysm and growth rate, either annually or sometimes biannually, or every 6 months. It really depends on the patient. And again, some of those medications that we can use are beta blockers, anti-lipemics, and then there are some antibiotics such as doxycycline that have shown to decrease the growth rate of an aneurysm. So how long do we wait until we have surgery? Well, on the size, 5.5 centimeters is the threshold for repair, which is almost 3 times the size of the normal diameter, which is 2 centimeters. So you have to think that's pretty stretched out. Sometimes it's greater than 5 with women, and otherwise surgical intervention can be done sooner if you have a very rapidly growing aneurysm. If you had a CT scan and then a year later it like doubled in size, we wouldn't want to wait another year and have it double again. So you would be at risk scheduled for surgery. Same with genetic disorders as well, just because their aorta is not as stable as somebody without it. So with the extremely high mortality rate, 90%, which is nuts, if it ruptured, clearly we want to do surgery prior to rupture. We want to try to prevent this at all costs. There are several things for patients who are scheduled for surgery to repair this aneurysm prior to rupture. We do want to make sure that preoperatively they're hydrated, they are NPO, we give them bowel prep as well, stabilize their electrolytes, make sure that they have an adequate H&H, replace them if we need to. So a little bit later in the PowerPoint, we'll go over some of the other considerations in nursing management. But the next few slides will be about some of the surgical techniques. So how do they repair for patients that will be taken care of? So in an OAR, an open aneurysm repair, they make a large abdominal incision and cut into the diseased vessel. They remove the thrombus and plaque, and then they suture a graft in place. This graft acts as a protective cover, like over the aneurysm to strengthen the wall. And you can kind of see in this picture here about the, just kind of what that looks like very simply. Obviously, I'm sure there's a lot more to it than that. But it does involve clamping below and above the aneurysm site, which is why we want patients to be, adequately hydrated because they can't be clamped for that long, obviously, because then we have tissue necrosis. This is another reason why aneurysms below the renal arteries are preferred, or they, wind up better, because during this cross clamping, you don't have to worry about perfusing the kidneys if it is below. Unfortunately, some patients, especially those who already have renal compromise, will be put on hemodialysis after a AAA resection, so after they have surgery to repair that aneurysm. Sometimes that hemodialysis or dialysis can be short-term until the kidneys kind of get it together and start working again. And unfortunately, if it's above the renal artery, sometimes that kidney function does not come back, or it's damaged enough that patients do require hemodialysis, for a prolonged period of time. One of the other procedures that is a little bit more common now, it is minimally invasive, is an EVAR procedure, endovascular graft procedure. So it involves placing a sutureless graft into the aneurysm, and it's done, they place a catheter through the femoral artery, and they thread a graft or sutureless graft or a stent into where that aneurysm is. And this is what it looks like. So as you can see, there's a catheter that's threaded up to where the aneurysm is. There are grafts that are placed in there. They look like little stents, but we call them grafts to wherever that aneurysm is. And it doesn't need to be sutured. Some of them have little hooks that will help that graft or that stent stay in place. Not everyone is a candidate for the EVAR procedure, but fortunately enough, because there's no blood flow, the blood will be flowing through those grafts and through the stents. So that aneurysm actually shrinks over time just because it doesn't have the pressure against those walls, those aneurysm walls, because now there's a different pathway for blood to flow. So there are several benefits to the EVAR procedure. Clearly, there's more rapid resumption of physical activity, which prevents against post-op complications, right? Like prolonged bed rest, and then we're more at risk for DVTs and pneumonia. We have shorter hospital stays, just an overall quicker recovery, and that results in reduction in overall cost too, and who doesn't mind paying a little extra or having not to pay a little extra. However, of course, these procedures do come with complications. So some of the specifics for the EVAR procedure. So the first and most common complication is an endo leak. And this happens when that graft is not adequately against the vessel wall. So blood winds up seeping past that vessel and into the old aneurysm site. Or sometimes those grafts can wind up with a tear, and then blood also gets into the old aneurysm site. Or if there's multiple grafts that are placed, sometimes there's leakage between those overlapping graft segments. So that's the most common one. And of course, we're always at risk for aneurysm growth if that endoleak does happen, because now we're having further pressure, from blood flow against that aneurysm wall, which increases our chances for rupture. We can have aortic dissections, which we cover in a little bit, and then some bleeding as well. But for the most part, endo leak is our main complication directly related to the surgery. Some of the other complications from an EVAR procedure are stent migration. So because that stent is just hooked in with these little hooks, it's not really sutured in, that graft can migrate, or that stent can migrate. Renal artery occlusion, which we talked about. Graft thrombosis. So we know that little foreign objects inside our body wants to clog them off or clot them off. So grafts are thrombogenic. They do like to clog, so that would be a complication. Site infection, hematoma from the incision, and if they do have some sort of a graft dysfunction, then they will require the traditional OAR, open aneurysm repair. A complication from open abdominal or open aortic repair is intra-abdominal hypertension, which is swelling that occurs in the abdominal cavity and eventually reduces blood flow to your vital organs that are in your abdomen. If this happens, patients need to go back to surgery and they get opened up again until the swelling decreases. While they're in there during the surgery, the initial surgery, they're moving around a lot of your bowels, and anytime you touch and manipulate the bowels, they swell. So that's one of the reasons why intra-abdominal hypertension is a complication and does happen. Prior to preparing somebody for surgery, one of our assessments that we want to make sure that we have a thorough H&P, watching out for signs of vascular problems that can happen from embolization, and really making sure that we get a thorough baseline assessment data. So when the patients do go to surgery, postoperatively, there is something good to compare it to. So if there's any complications or any changes, at least we can go back and see, preoperatively, what did they look like. We always mark and document the pedal pulses prior to surgery. They have special pen markers where you can draw on the skin, or sometimes people put tegaderm down, and then you can mark the pedal pulses, put an X with marker over the tegaderm, so you're actually not writing on the patient. But that's very important because oftentimes patients do have decreased pedal pulses because they were cross-clamped during surgery. So making sure, again, that we just have a thorough assessment data, baseline assessment. And then, of course, with rupture being so deadly, we want to make sure that we monitor for indications of rupture, and that we also notify family and patients about what to look for potential rupture. So sweating, paleness, tachycardia, weakness, change in level of consciousness, pain, especially in the abdomen, the groin, the back. Those would be signs that patients would want to report. So risk factor modification, like again, blood pressure control, smoking cessation, increasing physical activity, maintaining a normal body rate, controlling your lipid levels. Those are all things that we need to do to help patients reduce their risk factors, and also it will help them if they do wind up having reparative surgery to recover faster. So for any times that now we need interventions for aneurysm repair, there's a lot of different things to consider. We'll go through each of the body systems that the surgery can potentially affect, but really providing emotional support for patients and caregivers, because it's very scary to have aneurysm repair. So pre-op routines, patients will have bowel prep and be NPO the day before surgery. And the reason for the bowel prep is, again, because they're going in and manipulating the bowels. So we want them empty. Showering, doing that chlorhexidine shower. IV antibiotics are routinely done, but right before the incision is made to help decrease the incidence of infection. Patients are likely to go to an ICU after aneurysm repair, and they're going to have a lot of drains and tubes, and we'll go through what some of those drains and tubes are. So it's really important to let family members know so they aren't in shock when they go visit their loved one. So to maintain graft patency, it's really important to have normal blood pressure. If the blood pressure is too low, that graft can wind up failing if it's not being perfused, if we're not perfusing it. And obviously, if blood pressure is too high, that graft can migrate, it can tear, and other problems can happen. So it's really important to maintain normal blood pressure. It's not uncommon for there to be several medications that are ordered in case somebody is hypertensive. They'll order, like a hydralazine, which is a vasodilator, or they might have them ordered if their blood pressure gets too low, medications such as norepinephrine or phenylephrine to help keep their blood pressure up. So that's not uncommon. IV fluids and blood components as needed. We want these patients to stay hydrated. Anytime patients have abdominal surgery, we lose a lot of fluid. So be expected to give these patients lots of fluids. We can monitor that via CVP. We can monitor the, fluid in the vascular system pretty non-invasively because I'm sure they're probably going to have a central line anyway. Urinary output is so important. We just talked about how the kidneys can be affected. So what a better way than measuring urinary output and being accurate with that. So some of our cardiovascular monitoring, patients will likely have an arterial line to help monitor blood pressure more closely. Obviously, continuous ECG monitoring, antidysrhythmics and antihypertensive meds, along with medications to make sure their blood pressure stays sufficient enough. Pain control, and we do resume their cardiac meds quite readily as soon as they're able to. We do to make sure that we monitor their electrolytes quite frequently because either they can have dysrhythmias from those electrolytes disturbances. So keeping on top of those. It's likely that patients will have low-grade temps after the procedure, just related to the inflammation and the body trying to heal. But we do monitor for extremely high temperatures because that might be an indication of infection, especially with all those invasive lines. If I have an arterial line and a Foley catheter, I may or may not be intubated. If I have a central line, there's lots of different access points. The incision that can be the harbor for bacteria and an infection. Also monitoring WBCs and making sure that patients staying adequate with nutrition too, as ways to minimize the risk for infection. It is very likely that somebody will come out with an NG tube or an OG tube, depending on if they're intubated or not. And this is to help with stomach decompression, to help with some of that gas buildup that can happen, especially with manipulation of the bowels. And we really look for bowel activity by listening to bowel sounds and seeing if they are passing any flatus, because that would be an indication that their bowel function is returning. Any signs of like bloody loose stools would be a sign of bowel ischemia and would need to be reported to the provider. Also comparing our neurological and our neurovascular assessment with our pre-op data as well to assess for any neurological changes that could happen in surgery, or if those vascular changes can happen because of the emboli. So assessing for all of those. So peripheral pulses should be assessed at least every hour for the first few hours, and then every 4 hours after that. So that's another reason why patients are admitted to the critical care unit, because the frequent assessments that these patients require. And along with our pulses, our pedal pulses or most distal pulses, we also want to look for our other CMSTs. So our temperature, color, cap refill, all of those things. Patients will likely have a urinary catheter, which is great because we will be assessing their hourly urine output to make sure that their kidneys are back functioning. We also trend their BUN and creatinine levels, their kidney function test, really being sure to document their intake and output adequately and accurately, and then getting daily weights too. And then a CVP can be some of the information that we can obtain to help us determine fluid volume status, or at least fluid in the vascular space. Patients need to avoid heavy lifting for quite some time, depending on if patients have any post-op complications, etc., but it's for quite a while, many weeks. And then teaching signs and symptoms of complications such as infection, neurovascular changes that can happen from stent thrombosis, monitoring their temperature, or if they have increased pain to make sure that they call the doctor. Sexual dysfunction is a common problem in males after this surgery, so also providing support with that. All right, and our expected outcomes, so we want their graft, patent, obviously, with adequate distal perfusion. We want their kidneys to not be affected. We can measure this by having adequate urine output, and then no signs of infection. Those are our ideal situation here. All right, so that sums up our aortic aneurysms. Now we're going to be talking about aortic dissection. So aortic dissection is not a type of aneurysm. It results when there's a false lumen that is kind of formed, which blood flows through. And we'll see the picture in just a second. So as you can see in this picture, there is a tearing of the innermost lining of the artery, and it creates this false pathway. So blood actually gets into that tear and can create a false lumen, a false pathway, which blood flows through. Aortic dissection happens more frequently in men than women, and it also happens more frequently in the 6th and 7th decades of life, so in 60s and 70s. It can happen from trauma, hypertension, cocaine or meth abuse, connective tissue disorders, so some of the same risk factors as with aneurysms too. So aortic dissection happens because of the degeneration of the elastic fibers in the arterial wall, and also hypertension because it allows those arterial layers to become unstable and able to tear. Patients who have a dissection and are severely hypertensive will increase that dissection much more quickly than if somebody has controlled blood pressure. That false lumen or tract can wind up impairing perfusion to other vital organs. So very classic symptoms for an aortic dissection is the worst pain ever. It's very sharp and the worst pain ever. So when you see those, you should think aortic dissection. The pain can also mimic an MI, depending on where that dissection is occurring. But it's very sudden pain. It's not something that's progressive over time. It happens all of a sudden. The size and location of the aortic dissection really determines what kinds of other complications and symptoms will be present with dissections. If the dissection happens in the ascending aorta or the aortic arch, we're at pretty high risk for cardiac tamponade because some of that blood can leak into the pericardial sac, causing cardiac tamponade. And these are our clinical manifestations of cardiac tamponade: narrowed pulse pressure, muffled heart sounds, JVD. If the aorta does wind up rupturing, obviously bleeding out and death are fairly common. It's just as high of a percentage with dissections as it is with aneurysms if the aorta winds up rupturing. So since patients come in with sudden, sharp, worst ever pain, one of our chest pain protocols is to get an ECG to rule out MI, and then we would do other imaging such as chest x-ray and CT scan that could help detect the dissection. TEEs can also help with detection, and then we have MRIs as well, although most of the time MRIs take too long, and a CTA can give us the same amount of data. So our initial goal is to decrease blood pressure and myocardial contractility, because if we have increased pressure against those arterial walls, then the greater risk for that dissection becoming worse. So beta blockers are our drugs of choice, our medications of choice, and they are given IV drip. They're not given PO to help control hypertension to minimize the progression of that dissection. And then morphine is our preferred analgesic as well, because it relieves pain, it relieves anxiety, and it also helps decrease afterload a little bit. If patients have an aortic dissection and they're asymptomatic, they might be treated conservatively for a period of time. They will be on heart rate and blood pressure management with frequent follow-ups with CTs or MRIs, depending. Eventually, though, it's quite common that patients will need surgery quite quickly. It's not something that we usually wait a while on. For our descending aortic aneurysms, there's procedures to help with that dissection, very similar to the EVAR procedure. It involves putting a graft, placing a graft, over that dissecting piece of the aneurysm or the aorta. So open surgical repair is generally recommended for patients with a chronic dissection, or if somebody has other risk factors, then they'll have an OAR type of procedure. Again, with a graft placed where that diseased piece of the aorta is. Some of our other considerations for dissections, again, we want to minimize cardiac contractility and also hypertension. So really maintaining a quiet environment, helping to decrease anxiety and pain to inhibit that dissection from progressing, and also management of those IV antihypertensive drugs. In addition, frequent vital sign monitoring, peripheral pulse monitoring. So if we lost their peripheral pulses, that would be an indication that they might need surgery more frequently than, more readily than not, more rapidly. That's what I'm trying to say here, because that would be one of the complications that we would be monitoring for, and let the doctor know. Arterial pressure monitoring, so patients would have an A line, that way we could assess their blood pressure better and more frequently since it's continuous. Our post-op care is the same because it's pretty much the same procedure. Our EVAR and our OAR is the same as it would be for our aneurysm repair. So we already just talked about that. Redissections are common, unfortunately, so we still want to enforce risk factor modification and compliance with medications, specifically antihypertension medications, such as beta blockers. So because redissections are common, if pain returns or symptoms progress, they do need to seek immediate attention, immediate help. And that sums up our aortic disorders.